I'm Dr. Sameer. I have been given a topic on ARB in diabetics. I'll be discussing this topic. First of all, let me introduce myself. I've done my MD in internal medicine in 2019, and since then, I have been working in the Department of Internal Medicine and in the Department of Cardiology as senior resident for a period of 4 to 5 years. Currently, I am working as a consultant in the Department of Internal Medicine at Cabot Medical Institute. So let's start with the topic. It's an interesting topic regarding the use of ARBs, that is angiotensin receptor blockers, in diabetics, considering the renal safety of the drugs. ARBs, as we know, are amongst the most widely used antihypertensive drugs, the sartan group, as we call it, including losartan, telmisartan, candesartan, valsartan, and so on. Hypertension is an important independent risk factor for renal disease. And as we know, the things go down to the RAS system, that is the renin, angiotensin, aldosterone system. And use of agents that basically targets this RAS confers renal protection in addition to antihypertensive activity. There's an extensive evidence regarding the role of ARBs and ACE inhibitors with respect to the RAS system and with respect to the impact that it has on our patients. In addition to providing 24-hour blood pressure control, clinical studies in patients with diabetes shows that telmisartan improves renal endothelial dysfunction, prevents progression from microalbuminuria to macroalbuminuria, which actually decides the fate of these patients with respect to diabetic nephropathy. It also slows down the decline in GFR and reduces the proteinuria in overt nephropathy. Of note that I want to address here is that once you start these patients on ARBs, there might be an initial increase in your creatinine, or your creatinine clearance might fall a bit. That's because of the impact that this drug has on the eGFR, and accordingly we can notice that subsequent to this initial decline in eGFR or an initial increase in creatinine, your creatinine is going to get stabilized, and it is going to have an ultimate effect on these patients. Now, the renal protective effect of telmisartan or candesartan is not confined to the management of diabetic nephropathy only. You have a trial called as on-target trial that was done on both diabetics as well as non-diabetic patients and showed a significant improvement as far as risks of cardiovascular events are concerned. Now, RSSDI guidelines 2022 recommends on the use of ARBs and their combinations in patients with diabetes and hypertension. So ARBs have a maximal renal protective effect when compared with any other class of drugs. Oh, what is important is that you don't need to combine ARBs and ACE inhibitors together because of the risk of hyperkalemia and renal worsening that can happen with the combo drug. So what can we do then? Instead of combining ACE and ARBs, you can go ahead with combining ACE and calcium channel blockers, or ACE or ARBs and diuretics, particularly the thiazide diuretics, if you need these drugs to control hypertension in these patients. Now, the latest advance in heart failure patients and diabetic patients is the use of SGLT2 inhibitors. Again, ACE and ARBs form a good combo with these drugs, and they have a beneficial effect as far as estimated eGFR fall is concerned. Now, CCBs, that is calcium channel blockers, when added to ACE and ARBs, is associated with renal protective and cardioprotective. Again, combination of these drugs, whether it is CCBs with ACE and ARBs or SGLT2 inhibitors with ACE and ARBs, has ultimately been found to have a composite a good effect with respect to the progression of chronic kidney disease or the management of hypertension in diabetic patients. So what would be the recommendations? Once you have a diabetic patient, start the patient on ACE and ARBs, irrespective of whether he is hypertensive or not. You can have a significant impact on this patient's progress of disease. Thank you.